Good evening, everyone. My name is Celine Gallagher and I'm the Scientific Chair of the Australian POTS Foundation. I'd like to introduce Marie-Claire Seely, who is the CEO and Founding Director of the Australian POTS Foundation. We will be your moderators for this evening's webinar. On behalf of the Foundation, I welcome you all to our POTS for Practitioners webinar series on mast cell activation disease. I would like to begin by acknowledging that we are hosting this webinar from the lands of the Kaurna people. I also acknowledge the traditional custodians of the various lands on which you all join us from today, and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Before we get started with this evening's webinar, just a reminder that all questions need to be submitted via the Q&A button, which can be found at the bottom of your screen. We will endeavour to get through as many of these as we can at the conclusion of tonight's presentation. This webinar is also being recorded and will be available via the Australian POTS Foundation website within the next few weeks. I'd like to give a very special thanks to our sponsors of this evening's event, Peter and Sammy Limcroft. You can find more information and blogs from Sammy by visiting her website or finding her on Instagram. Please scan the QR code on your screen to learn more. We are very grateful for Peter and Sammy's support in helping to make tonight's webinar and Dr. Afrin speaking to her in Adelaide possible. Tonight is a very special POTS for Practitioners webinar, and we are incredibly lucky to be joined by internationally renowned expert, Dr. Lawrence Afrin. Dr. Afrin earned a Bachelor in Computer Science at the Clemson University in 1984, and then an MD at the Medical University of South Carolina in 1988, where he also pursued an internal medicine residency and hematology oncology clinical and research fellowships. Whilst on faculty at the Medical University of South Carolina from 1995 to 2014, he was active in undergraduate and graduate medical education, information technology, and educational administration, including a fellowship program director for 13 years and practice and research in hematology, oncology, and medical informatics. Since the mid-2000s, his clinical work has increasingly focused on hematology, especially mast cell disease. Dr. Afrin also directed the Medical University of South Carolina's Myeloproliferative Neoplasms Clinical Trials Program. Whilst at the University of Minnesota from 2014 to 2017, furthering his interest in mast cell disease, he also served as Assistant Education Director and IRB Reviewer. In 2017, he left the University of Minnesota to develop an independent institute located in the greater New York City area for advancing care, research, and education in mast cell disease. And he is also working to develop a global investigative network in this area. He has served on national panels on oncology education and quality care and has spoken widely in his areas of focus. He has an extensive record of peer-reviewed publications, including some of the most highly accessed articles about Mast Cell Activation Syndrome and a popular book in the field. Dr. Afrin also serves on the editorial boards for several journals and medical advisory boards for various organizations, including the Mastocytosis Society and the Ehlers-Danlos Society. Thank you very much for joining us tonight, Dr. Afrin, and welcome.
Thank you very much, Celine. Let me just check technically here. My voice is coming through okay on the webinar. Okay, and like to thank the Australian POTS Foundation and you, Marie-Claire, and Celine, and sponsors, Sammy and Peter Lincroft, for the opportunity this evening. I think we're ready to get started. Should I share screen?
Yes,
Okay.
thank you.
I think this should do it. How does that look?
Beautiful.
Okay. All right, so let's go ahead and get started here. Our learning objectives will be to review basic concepts regarding the mast cell activation disorders, spending most of our time on the newest mast cell disorder to be recognized, mast cell activation syndrome. We'll review the general clinical presentation of MCAS and talk at a high level about the approach to diagnosing and treating MCAS, though we don't have time this evening to go into too many of the details of that. No conflicts of interest to disclose, and I just want to make it clear that any treatments discussed tonight are not approved by the FDA or any regulatory authorities anywhere around the world for treatment of this disease. Not yet. I mean, even the regulatory authorities are pretty much unaware the disease exists yet. All things in due time. So the treatment options discussed in this presentation are all based on consensus viewpoint or expert opinion. So we'll talk briefly about what we've long known about mast cell disorders, the very prevalent allergic disorders, and the very rare disease, the cancer of the mast cell called mastocytosis. But we'll spend most of our time talking about MCAS and wrap up at the end very briefly talking about research opportunities in this area. So I'd like to start by helping the audience wrap their heads around one of the most challenging aspects of this disease for both patients and practitioners, coming to grasp and to accept the extreme variability or heterogeneity with which this disease behaves from patient to patient to patient. And we'll start with brief case presentations of the first two cases of this disease I came to, in whom I came to recognize that a mast cell activation syndrome was at the root of their troubles. I'm a hematologist oncologist, so at the time I saw these patients a number of years ago, I was routinely getting referred patients for hematologic and oncologic issues. The first patient came to see me for what had been diagnosed in her as a fairly uncommon cancer of the red blood cell called polycythemia vera, in which you basically have a malignant overproduction of red blood cells. At least that's what she had been thought to have. The second case we'll talk about briefly had exactly the opposite problem. Her bone marrow had completely given up making red blood cells. She had presented with or had been referred to me for further evaluation for a disease called pure red cell aplasia. And I don't want to have anybody come away from the talk tonight thinking that hematologic issues are always seen in mast cell patients. Again, I'm a hematologist. That's why I see hematologic cases. But many mast cell patients don't have any identifiable hematologic problems. Instead, they have many other problems. So again, to better illustrate the variability of this disease, I'll present a third case that heads off in a totally perpendicular direction, a disease that I had never even known existed until I ran into my first case around the same time I ran into my first two cases of what turned out to be MCAS. So we'll start with the first lady. Fairly healthy lady, into her 30s, began noticing a migratory rash, and over time, variety of other issues. As you see here, she occasionally saw her doctor. Fairly stoic woman, didn't go to the doctor very much, but the evaluations she underwent were all negative. No causes for any of these problems were found. She just lived with it, figured out how to deal with it. Finally, the fatigue got so severe, she was in her early 50s at this point, that in 2005, she again went to her primary care doctor, who very reasonably suspected this severe fatigue was due to anemia, too few red blood cells. So he checked a complete blood count, a CBC, and was surprised to find she actually had a mildly elevated hemoglobin and hematocrit level, increased numbers of red blood cells. He referred her to the local hematologist, who did a battery of testing at that point that actually was not completely congruent with standards at the time for diagnosing polycythemia vera, and with a somewhat incomplete battery of testing and some very mild abnormalities on some specialized tests, he made a diagnosis of polycythemia vera, again, this rare cancer of the red blood cell. This turned out to be an incorrect diagnosis, but that's what he diagnosed, and he began standard treatment for that disease, which was to um, actually take blood out of the patient, uh, 1 unit of blood every week or two, until the patient became iron deficient and could no longer make excessive amounts of red blood cells. And you'd like to think that if you're giving, if you made the right diagnosis and you're giving the right treatment for the right diagnosis, the patient ought to get better. She did not get better with this very standardized treatment for PV, and she just kept getting worse in a wide variety of fashions, as you see here, symptoms that PV can't possibly account for. And she was asking the local hematologist repeatedly for referral for a second opinion. He kept insisting there was no need for such, because he was certain he had made the right diagnosis. He actually doubled the intensity of the treatment, and she just became more anemic and was not getting any better. So finally, she self-referred to the local, to a nearby academic medical center, and long story short, wound up in my clinic. And it took about 60 seconds of history to realize she couldn't possibly have PV. I mean, I'm a hematologist. I know the way that disease behaves. And yes, she did initially present with elevated red blood cells, as we see in PV, but she had far too many other symptoms that PV can't possibly account for. So the question became, what disease do you have that can not only present with elevated red blood cells, but also all of these other symptoms? And from the early times in my evaluating the patient, I had suspicions she had this rare mast cell cancer called mastocytosis, but the testing for that did not show mastocytosis in bone marrow biopsies and skin biopsies, and I had already proven, done some specialized testing to prove she did not have PV. And as time went on, I was more and more puzzled. It kept smelling, so to speak, like mastocytosis, but I couldn't find the evidence. And as I did more reading about this disease, in which I had received very little training, I learned about other aspects of mast cell biology nobody had taught me, and found there are other mediators besides tryptase, for example, to go looking for evidence of mast cell activation. I learned about this one particular mediator called prostaglandin D2. Turns out to be fairly challenging to accurately measure it. I made every mistake possible in attempting to measure it, and we actually had to try several times to measure it before we finally got an accurate reading that indeed was elevated, suggesting there really was a mast cell disorder here. But as an oncologist, we're taught that if you're going to diagnose a cancer, you have to find the tissue with the cancer in it. And I knew it wasn't in the bone marrow, it wasn't in the skin, so thought about where else to go looking for it. Decided to go looking in the GI tract, probably the safest place to go looking. We did scopings, the upper GI tract and the lower GI tract. Everything appeared normal at the macroscopic level. I had the gastroenterologist take biopsies all throughout the GI tract anyway. The pathologist initially tried to insist to me that on routine processing of these biopsies were the most textbook normal he had ever seen in his career. There was absolutely nothing wrong with them. But then when I insisted he go do the additional specialized processing, so-called CD117 staining that I had learned by that point was necessary for a pathologist to be able to see the mast cells that are present in the tissue. He then somewhat reluctantly went and did that, and then called me back and said, very strange situation here on the routine tissue processing that you see here, the hematoxylin and eosin staining, the GI tract tissues indeed look completely normal. But with the CD117 staining, it immediately becomes clear that many of the cells that had been thought on routine H&E staining to be just normal lymphocytes that are typically found in these tissues, no, in fact, they were not lymphocytes, they were mast cells. And in fact, the numbers of mast cells seen, mast cells are normally found in many tissues throughout the body, but this number of mast cells was significantly greater than normal. Still, this wasn't anything even remotely resembling what would be expected with mastocytosis, but still, it was definitely abnormal. And so I called her back into the clinic and said, I don't know what to call this other than atypical mastocytosis. A typical case of mastocytosis, we would find it in the bone marrow or the skin, but she didn't have that. So I said, I don't know what to call it other than atypical mastocytosis. There was virtually nothing in the literature at the time about how to treat this. There was just beginning to emerge in the literature some suggestions that very low doses of a drug that had come to the market just a few years earlier called imatinib, that was kind of the wonder drug that had been developed at that time for a type of leukemia called chronic myelogenous leukemia. Imatinib was terrific for CML, and a couple of years after that, we began learning that much lower doses of imatinib actually worked very well for very unusual cases of mastocytosis that did not feature this one particular mutation that we'll get to in just a moment that is almost always found in mastocytosis. So given how atypical our case was, we decided to try this drug, which at least in the US is extraordinarily expensive. We started at the lowest available dose for a week. There was no guidance in the literature how to dose this. It's kind of flying by the seat of my pants, to be honest with you. And I said, after a week, if you're tolerating it okay, but you're no better, then double it and come back in a month and we'll see how you do. Go from there. And so she came back in a month and told me the first week she'd been tolerating it fine, but didn't see any improvement with it. And then she doubled the dose as instructed. And she woke on the morning of the 5th day at the doubled dose. And she hadn't even moved yet. She just woke. She was lying there in bed. Ordinarily, for the last many years, it had been taking her 2 hours or longer every morning just to crawl out of bed. She was so fatigued every morning. And she woke that morning acutely aware that all of her symptoms were gone. Not just the fatigue, everything was gone. She was feeling perfectly well. She leaped out of bed. And long story short, she's just been running like a rabbit ever since. And I mean, she had had to previously give up her business and just put her entire life on hold. And now she was able to get back to living again. The improvement has been sustained for more than a decade now. And it was just really nice to see that improvement. And literally the next day after I saw that initial response is when I did an initial consultation on this lady, also in her 50s, who had a few years earlier been found, she had presented with severe fatigue. She had been found to be severely anemic. She had been diagnosed by 3 different community hematologists and 2 academic hematologists as having this very rare bone marrow condition called pure red cell aplasia, in which the marrow just completely gives up making red blood cells. Usually this is caused by one or another of certain types of viral infections, sometimes also some chemical exposures, but in her, there was no apparent cause for this. She had been tried on all standard treatments for PRCA. Nothing had helped. She was intensely dependent on red blood cell transfusions every 2 to 3 weeks to maintain a hemoglobin level of about 5 to 6 compared to normal being about 13 to 14. And finally, she came to see me, and because of what I had learned about mast cell disease in the context of working up the first patient, and because this lady with PRCA had already undergone so much prior evaluation that it ruled out every other possible cause of her anemia, I began to realize when I learned from her that it wasn't just the fatigue she was having. She was having 57 other symptoms that PRCA could not possibly explain, and I recognized that mast cell activation had potential for explaining these symptoms. So I was able to run the testing, which at that point I had gotten much better at doing. We immediately found the evidence of it. We diagnosed her not with atypical mastocytosis, but rather a new term that was just coming in the literature at this point in early 2009, Mast Cell Activation Syndrome. I started with some cheap drugs on her, antihistamines, just a few dollars a year instead of $150,000 a year imatinib, and we got her hemoglobin up to 8 in just a month, and she was no longer requiring any transfusions. That was a big improvement, but 8 is a good bit shy of 13, 14, so I tinkered with some other mast cell targeted drugs in her, didn't make any progress, finally put her on low dose imatinib, and in just 6 weeks, the hemoglobin was fully normalized. We actually lost that response to imatinib about a year later, and I was then able to try another drug at that point that was actually a good bit cheaper than imatinib, but which previously I had not been permitted to try in her because of her prior insurer just not allowing doctors to prescribe that drug, but she had actually changed insurers by that point. So I had a new opportunity to try this drug, and once again, in just a month, achieved full remission. Now, this lady with the burning mouth syndrome, I had already been working on her for about 4 years at the time I came across the ladies with polycythemia and pure red cell aplasia. The lady with burning mouth syndrome, again in her 50s, she had fairly acutely developed this intense pain, burning pain throughout her mouth. Actually, it was all throughout her GI tract, but by far the worst in her mouth. She saw every specialist there was to see, and nobody could figure out why her mouth was burning until finally a clever endocrinologist wondered whether this might be, this symptom might be a product of one or another type of a rare class of cancers called the neuroendocrine malignancies. So he ran a test called the chromogranin A test in the blood. And this is a test that is often elevated in patients with neuroendocrine tumors. And he found a 100-fold elevated CGA level in her. and she did not have any other apparent reason for this elevation. So he and every one of her other doctors thought, well, she must have a neuroendocrine tumor, and she got referred off to oncology and landed in my clinic. And when I first went in to see her, I was expecting to see somebody who looked like she had advanced cancer, which is what you would expect from a neuroendocrine tumor that is producing such a humongously elevated CGA level. And I was surprised to see that, yes, she was certainly miserable from her pain, but she otherwise didn't look like she had cancer of any sort, advanced or not. Nevertheless, I had not been taught any other cause for severe elevations in CGA other than neuroendocrine tumors. You don't want to know how much money I spent looking for that neuroendocrine tumor, but couldn't find it. I consulted the top 5 experts in the US on neuroendocrine cancers. They all said, you've done a great workup. We don't understand why the testing is negative, why you can't find it, but there is no other cause for such a hugely elevated CGA. It has to be a neuroendocrine tumor. Why don't you just keep repeating the same, $50,000 set of tests every 6 months, and surely you'll find it at some point. And that just sounded ridiculous to me. So no, I did not do that. I spent the next few years continuing to think about what other diseases might be driving this huge elevation in CGA. And finally, in the context of learning about mast cell disease with the other 2 patients, I learned that mast cells actually are capable of producing chromogranin A, and nobody had ever taught me that before. And so at that point, I was able to ask our pathologist to go back to the old GI tract biopsies, which of course had already been taken from this lady with burning mouth syndrome. And indeed, we found the increased numbers of mast cells there, and we had a diagnosis, and with just antihistamines and some other simple drugs, her pain was remarkably improved essentially overnight. And I then called up our chief oral surgeon and said, do you have any of these burning mouth syndrome patients that I've never previously heard of before? And he said, oh, yeah, we got plenty of them. And they all get sent to us because nobody else knows what to do with them and doesn't want to deal with them. And we sure don't know what to do with them because we don't know what's causing the disease. And we can never find anything wrong. And then we hate seeing these patients. And I said, well, I've got an idea. Why don't you send me a few of them? And he, of course, was tickled to do that, and sent me them, and I began evaluating them. And to be clear, they certainly had different patterns of mast cell disease in each of them. But nevertheless, we did prove they actually had mast cell disease. And each and every one, they all responded to various mast cell targeted therapies. So I know I've spent a lot of time on these case presentations, but I thought it's important to understand that this disease can produce highly diverse presentations, but ultimately they're all just different variants of the same root issue of chronic inappropriate activity of some portion of the body's mast cells, what we're now calling a mast cell activation syndrome. So how is it possible for one disease, so to speak, to actually present so diversely, and could other weird presentations be possible? We'll answer those questions in a few minutes, but let's briefly talk about what we've long known about mast cell disease. They say if you don't learn from history, you'll just be doomed to repeat it. So what we've long known about mast cell disease, first of all, the very prevalent allergic disorders. Not all of them are driven by mast cell dysfunction. There's some other types of cells that can also drive allergic disorders, but a large proportion of the allergic disorders are driven by mast cell misbehavior. These are very prevalent diseases, roughly 10 to 20% of the world population. The incidence, the prevalence have been increasing in the modern era. Lots of theories about why that is, why that might be, nothing proven yet. We know these diseases are driven by a very complex mix of genetic and environmental factors. And fortunately, other than the relatively small fraction of these patients who unfortunately succumb to fatal anaphylaxis every year, otherwise there's relatively little mortality from these diseases, and therefore it becomes an issue of quality of life for the duration of a fairly normal lifespan with these patients. Contrast the prevalence of the allergic disorders with the extreme rarity of mastocytosis, the cancer of the mast cell, first seen as in the cutaneous form of urticaria pigmentosa. You're seeing pictures here of the rashes of UP. First recognized in the 1860s. Another decade went by before the mast cell itself was first discovered. Another decade to realize that UP was a malignancy of the mast cells. Another half century before we realized this cell can cause not only cutaneous cancers, but also systemic and internal malignancies. And that was about the time we began realizing the mast cell produces what we are now calling various mediators, starting with heparin and then histamine and tryptase and so forth. We began developing classification systems for the different forms of mastocytosis in the mid-90s. We learned there's this one particular mutation, the KIT codon 816 mutation, that is found in almost every case of mastocytosis. And just a few years later, actually the same year that the WHO came out with its classification system for mastocytosis that we've been using ever since, that's the same year that imatinib hit the market for CML. And as I said, it was only a few years after that we realized imatinib at much lower doses was very helpful for the rarest of the rare cases of mastocytosis that did not have the KIT codon 816 mutation. And as the last couple of decades have gone on, we've increasingly realized that in patients with mastocytosis, and this is in remarkable contrast to most other types of cancer, it is not the excessive proliferation of these malignant mast cells that's actually causing the symptoms in patients with mastocytosis. And instead, it is the inappropriate activation of these malignant mast cells that's actually causing the symptoms. So this was the landscape of mast cell disease we previously knew about. Think of it as a mountain. And this is not drawn to scale, but you get the idea that the vast majority of the mountain are the allergic disorders, and then the tip of the mountain are the different forms of mastocytosis. Now, the whole mountain features inappropriate activation of the mast cells, but just the tip of the mountain additionally features grossly inappropriate, cancerous levels of proliferation of the mast cell. So now we get into the realm, the era of mast cell activation syndrome. Now, the notion that the hypothesis that there ought to exist a disease that we now recognize as MCAS. This was first published in the 80s. Took another 20 years or so before we actually saw the first case reports of MCAS published. And that was the same year that we saw the first studies coming out of the University of Bonn showing that almost every patient with MCAS has various mutations in KIT. It's just that it's almost never that codon 816 mutation in KIT that you almost always see in mastocytosis. And instead, the MCAS patients have a plethora, a real menagerie of other mutations in KIT, and as it turns out, in a lot of other mast cell regulatory genes as well. And in the following years, we began realizing that all patients with mast cell disease, or virtually all patients with mast cell disease, have many other genes besides KIT. KIT is the dominant regulatory element in the mast cell, but there are plenty of other regulatory genes in the mast cells too. And we began finding mutations in many of these other regulatory genes as well. In 2010, the good folks in Bonn came out with a follow-up study, again showing almost every MCAS patient has a menagerie of mutations in KIT, but almost never the codon 816 mutation. And they also, in that study, looked at healthy controlled subjects and found almost no mutations in those patients. And that strongly implicates that it is the mutations in the mast cells that are driving the misbehavior, the inappropriate activation of those mast cells. Now, that same year, 2010, is when we saw in the literature the first proposal for changing the terminology in this area of disease for what we had previously been calling just mast cell disease. We said, no, we ought to be calling it mast cell activation disease, just to keep reminding ourselves, for the doctors to remind themselves that first and foremost, what is going on in every patient with mast cell disease is inappropriate activation of the mast cells. And then there's this tiny subset that also has the cancerous proliferation of the mast cell that makes those patients cases of mastocytosis. Now, this paper in 2010 included the first proposal for specific criteria for diagnosing mast cell activation syndrome, but there were many problems with that proposal. And a few months later, an alternative proposal emerged in the literature, different criteria. And full disclosure, I was one of the co-authors on that proposal. The original proposal was revised several months later, but still was significantly problematic and has remained so to this day, in my opinion. The WHO actually revised its diagnostic criteria for mastocytosis most recently in 2016. They recognized at the time there was a lot of controversy going on with diagnostic criteria for MCAS, and they wisely just stayed out of it. That may change in the future, but right now there is no consensus from the WHO about how to diagnose this disease. And in 2020, that alternative proposal underwent a little bit further tweaking and has now been termed the consensus 2 diagnostic criteria to distinguish from the original proposal, the so-called consensus 1 diagnostic criteria. So this is the new understanding of the total landscape, so to speak, of mast cell disease. What formerly was the mountain of mast cell disease is now itself revealed to be nothing more than the mere tip of a vastly greater iceberg of mast cell disease. The full iceberg, again, all of these disorders feature inappropriate mast cell activation, and it's just the tip of the iceberg that additionally features the cancerous proliferation of the mast cell that we call mastocytosis. Now, the diseases above this waterline of fairly easy clinical recognizability, the allergic disorders and mastocytosis, fairly easy to clinically recognize those diseases. But all of these other forms of mast cell activation below this waterline of easy clinical recognizability, this is what we're presently calling MCAS, and there's no question there is an uncountable number of variants of MCAS embodied in this bulk of the iceberg. We just haven't learned yet how to really distinguish, how to accurately distinguish one variant from another. We'll figure it out in time, but it's going to take quite a bit of time to figure this out. So this is just a different view of that landscape. We see that the prevalence of the different disorders, the different mast cell disorders, ranges from the ultra rare mast cell leukemia, the worst form of mastocytosis, all the way up to mast cell activation syndrome, which by the latest epidemiologic research is being found in multiple studies to be as prevalent as about 17 to 20% of the general population. And yes, the implication of that is exactly what you're thinking, that in truth, every doctor has been seeing these patients left and right all day long, every day, their whole career. They just couldn't previously recognize these patients for the mast cell activation syndrome they've got in them because they've never been taught that such a disease exists. Few other basic facts about normal mast cell biology. These cells are born, for the most part, of the stem cells in the bone marrow. They leave the marrow fairly shortly after being born, so to speak. They circulate in the blood only briefly before exiting into various tissues all about the body. Especially abundant at the environmental interfaces and in the walls of all vessels and the sheaths of all neurons. And this is exactly where you'd expect them to be positioned to best serve their principal role in human biology of being the first line sentinels against attacks and assaults upon the human body. We'll move on here. So their principal role is to monitor the tissue environment around them and to synthesize various substances that we generically call mediators, that are some of which are actually pre-manufactured, pre-stored inside the mast cell, so that when there's an instantaneous need for the mast cell to respond to a given assault upon the body, there are some mediators that can be instantly released from the mast cell. Other mediators get produced only after an assault upon the body has been recognized. Finally, let me point out that KIT is a transmembrane receptor on the surface. It brightly studs the surface of the mast cell. You find 10-fold more copies of the KIT molecule studding the surface of the mast cell compared to any other known type of human cell. And normal high numbers of KIT at the mast cell surface, normal numbers of normally functioning KIT, that is unmutated KIT, need to be present to support many critical mast cell functions, including normal mast cell proliferation and normal activation of the mast cell. Sort of an obligatory cartoon in showing that kind of a simplified illustration of the biology, the molecular biology of what's happening here. The natural human molecule that binds or docks with KIT is stem cell factor, SCF. And when SCF binds with a pair of KIT molecules at the surface of the mast cell, there is an immediate change in the three-dimensional conformation of the portion of KIT that is inside the mast cell. And that conformational change kicks off instantly a wide range of downstream molecular events. This is actually a gross oversimplification of all that happens when KIT comes to be activated by SCF. But it's all of this normal activation that leads to normal mast cell functioning. So when the mast cell actually gets activated by sensing some assault upon the body, and this video is courtesy of immunologist Peter Smith at Griffith University. The granules in which the mast cell has pre-manufactured, pre-stored all these mediators, these granules then migrate to the surface of the mast cell and then release all these mediators into the environment around the mast cell. And these mediators then diffuse into the tissue environment. They come to bind with receptors that are specific for each of these mediators. The receptors that are present on the surfaces of many other types of cells in these tissues, and it is and when a given mediator binds with a receptor, a corresponding receptor on the surface of another cell, it immediately induces that cell to begin adjusting its operations in a fashion that the body, in a fashion that's needed to help the body overall resist and recover from whatever the insult upon the body was. It's an extraordinarily complex system that has developed through evolution over the last 500 million years. And as long as the mast cells are putting out the right mediators in the right amounts, right times, right durations, right places in the body, then we stay healthy. Our ability to tolerate assaults upon the body and to recover from them is quite remarkable. There are many triggers that can set off activation of the mast cell, that can trigger the mast cell to release its various mediators. The classic mechanism doctors are taught in their medical training is when an allergen comes to engage a type of antibody molecule called an IgE antibody that has been pre-bound to a mast cell. When the allergen binds to that IgE molecule, you instantly get changes inside the mast cell that ultimately result very quickly in the mast cell activating and releasing various and sundry of its mediators. So that's the classic method of activating a mast cell. But there are lots of other ways that mast cells can be activated through various physical forces, various by the engagement of other molecules in the body with receptors on the surfaces of the mast cells. The mast cell has receptors for histamine, receptors for complement, receptors for various neuropeptides, receptors for opioids, receptors for benzodiazepines, receptors for cannabinoids, and also these receptors called toll-like receptors. This is actually how the mast cell recognizes when infection is invading into the body. And the mast cell can then begin releasing various mediators to combat, to assist the other parts of the immune system in combating infection. So to give you a sense of just how vigorously the mast cells degranulate and release their mediators, this video is courtesy of Dr. Theo Theoharides at Nova University, a three-dimensional video microscopy showing what happens when one molecule of this mediator called substance P comes to engage with a substance P receptor on the surface of the mast cell, and you see this explosive degranulation of the mast cell. It really happens that fast, that all these mediators are being released from the granules into the environment around the mast cell. So the mast cell is capable of synthesizing and releasing many mediators. You see a listing of mediators here in a font that's almost too tiny to read, and that's kind of the point, that this long list of mediators shown here is itself only a tiny subset of the total range of mediators that the mast cell actually is now understood to be able to produce and release. Most doctors go through their decade of training and are taught that the mast cell produces a grand total of 2 mediators, histamine and tryptase. And so if the doctor can't even imagine that a mast cell is capable of doing much more than causing allergic problems, that's a large part of why their thinking is limited in that scope. But the mast cell is now understood to produce more than 1,000 mediators, each of which has a huge range of effects all throughout the body. And you might wonder, how could such tiny molecules cause such massive symptoms at the clinical level? We already have a very good analogy in the electronics world, just as molecular scale transistors, and really transistors in the modern era really are crafted at the molecular scale. But through appropriate amplification mechanisms, one little 2 nanometer transistor can open the floodgate on a dam or launch a rocket into space. Well, there are similar, there are very potent amplification mechanisms for the mast cell mediators in the human body. And when they activate, you can very quickly get a vast spectrum of illness, as seen with this patient on the left here. But when you finally get control over that inappropriate release of the mast cell mediators, then you can very quickly gain significant improvements. These are the diagnostic criteria most recently developed by the WHO for mastocytosis. Not worth going into the details here. Suffice to say, they do a fairly good job very specifically defining cases of mastocytosis, but they also create a problem in that it turns out again, remember, mastocytosis is a rare disease, but it turns out there are an awful lot of patients, and as I mentioned before, about 20% of the population, who have symptoms that you could reasonably suspect is coming from mastocytosis, and yet you cannot find the mastocytosis in these patients. They don't have the cancerous proliferation of the mast cells. These patients present superficially with a wide variety of different clinical problems. They see many different specialists who, of course, only look at the patient from one particular angle and don't look at the big picture. And it creates a big problem. What do you do when you have a disease that it looks like a duck, it acts like a duck, it quacks like a duck, but it's not a duck. It looks like it looks like mastocytosis, it acts like mastocytosis, but it's not mastocytosis. Well, this is the situation in which we now have to consider mast cell activation syndrome as a potential diagnosis in these patients. Don't have time to go into the consensus one diagnostic criteria for this disease. Suffice to say, as you can see from all the red here, there are an awful lot of problems with these criteria. Happy to discuss it more in the Q&A if you want, and this has also been presented in the literature. And all I want to say about the consensus 2 proposal, this proposal is structured similarly to how the criteria for mastocytosis are structured. And the way in which we go about diagnosing MCAS in most patients these days is by combining a finding of the major criterion of chronic symptoms attributable to inappropriate mast cell activation. And we combine that with laboratory evidence of mast cell activation. So it's a combination of this major criterion and this one particular minor criterion. This is how most MCAS patients get diagnosed these days. There are increasing estimates of prevalence of this disease, increasing evidence that mast cells are integrally involved in a wide variety of chronic inflammatory diseases, but we have yet to figure out whether these diseases are actually rooted in mast cell misbehavior or not. Just an awful lot more research to be done to figure that out. We do know, again, from the work in Bonn, that in almost every patient with MCAS, you can find a wide variety of mutations in KIT. In fact, most of these patients are now proven to have multiple mutations in KIT. But we got a real problem in the clinic in that we don't have assays yet, no testing for any of these mutations except the codon 816 mutation, which is almost always found in mastocytosis and almost never found in MCAS. And this is why at present, because we can't do the testing to prove the mutations are present in the typical patient in the clinic, we wind up having to conclude that the patient has an idiopathic form of MCAS rather than a primary form of MCAS. Come back, I don't know, 20 years from now when this testing to find these mutations in the mast cells is commonly available, and then we'll be officially diagnosing most of these patients as having primary MCAS. Just to illustrate here, the menagerie of mutations that are found all throughout the different pieces and parts of KIT in different patients with MCAS. So this is what leads us to answer the original question: how can one disease cause so many different presentations? You do the math. Mast cells produce and release not just scores, but hundreds of different mediators. Any one mutation in one mast cell regulatory gene that excessively activates the mast cell is going to lead to inappropriate release of multiple mediators that create some potential for multi-system illness and variability from one patient to the next, depending on which mutation is present in KIT in that patient. But it gets more complicated than that because it's not just one mutation in KIT. In each of these patients, we know most of these patients have multiple mutations in KIT, in creating even more potential for illness and variability. But it's more complicated than that because we know it's not just KIT that's mutated. We know it's multiple mast cell regulatory genes that are mutated in most of these patients. And it gets even more complicated than that because it's not just one mediator these patients are inappropriately outputting from their mast cells. It's multiple mediators, and each mediator doesn't have just one effect. Each mediator has its own unique, pretty large array of effects, locally, remotely, directly, indirectly, so on and so forth. So this is how one disease in many, many, many different variants, likely genetic variants, winds up causing so many different presentations. So if it looks so differently in different patients at the superficial clinical level, can you come up with any overarching description for it? And sort of. I mean, this is the best I've been able to come up with over 15 years working in this area. This disease presents as a chronic multi-system illness of general themes of inflammation. So chronic multi-system inflammation, that's the universal constant in these patients. Again, the details of the inflammation are different from one patient to the next. But in general, it's chronic multi-system inflammation plus minus allergic phenomena, plus minus abnormalities in growth and development. And that's in there too, because many of these mast cell mediators actually are integrally involved in guiding growth and development in all tissues throughout the body. The disease typically begins fairly early in life, but over time, as patients are subjected to major stressors, the baseline level of misbehavior of the disease can escalate to a whole new worsened level of misbehavior. It's almost always a multi-system disease. They're always inflammatory, a perplexingly inconstant course, and there are a lot of reasons for that. Tryptase is a reliable marker, almost always strikingly elevated in mastocytosis, but it's a very poor marker of activation of the mast. So it marks for the number of mast cells in the patient's body. So if you have a cancer of the mast cell, it's going to be quite high. But if all you have in terms of mast cell disease is inappropriate activation of the mast cell with relatively little to no proliferation of the mast cell, tryptase is going to be elevated little to none, usually none. And instead, you have to go testing for other mediators that the mast cell puts out, and that is quite challenging business. Not that it can't be done, it's just you have to learn how to do it. These patients, understandably, having so many different symptoms, they see many doctors, acquire many diagnoses. Quite often, no causes for their problems can be found. They are labeled by their doctors, their families, their friends as psychosomatic. And if you were one of these patients and you underwent many evaluations, you couldn't find any explanations, you were told by your doctors and your families it's all in your head, you would then stop telling people about your symptoms. So it becomes very important for the doctor who comes to suspect that MCAS might be present in a given patient. He needs to do a very careful history, extracting these complaints out of a patient who learned years ago not to report these complaints. So the symptoms are all over the map, the constitutional issues, as you see here. And then these are the patients who have the odd and the prolific reactivities, the long allergy lists that don't make any sense to most doctors. And then as you go system by system by system, what you see is inflammation, inflammation, inflammation. It's just the superficialities of it are different from system to system to system, but it all boils down to inflammation, inflammation, inflammation in every system in the body. And in the interest of time, I'm just going to kind of go through this quickly. And again, every system in the body can be impacted. You saw at the beginning of the presentation how the hematologic systems and the clotting systems can be impacted. The immune system can certainly be impacted in a variety of fashions with this disease. The endocrinologic and metabolic systems can be impacted. Growth and development in various tissues can be driven by different forms of mast cell disease. So with a disease that superficially presents looking so differently from one patient to the next, what's the best way to go about diagnosing it at present? I've learned that you need to circle back to Old Faithful, a complete history and exam, and restore your faith in Occam's razor. I mean, honestly, which of these two scenarios is more likely? Is it more likely that this poor patient who has acquired 74 different problems on their problem list, that every one of those problems has developed independently of the other, or do they have one diagnosis that actually is biologically capable of driving most or all, probably all, of the symptoms that have long been going on in that patient? That's obviously the more likely explanation. It's just unfortunate that the disease, the diagnosis that fits the bill here is so extraordinarily biologically complex that my learned profession didn't even start to learn until just 15 years ago that this disease actually exists. And it's still the case today. Most doctors haven't even heard of this yet. And those who have heard of it still don't have much familiarity with it. So go easy on your docs. They're doing the best they can, working within the box that was constructed for them through their long and expensive training. Now, just because somebody has one disease, even a very complex disease like MCAS, doesn't necessarily mean they can't have any other diseases. So it is important to still be thinking about other diagnoses that might overlap with at least some of the symptoms that MCAS can drive. And so an astute diagnostician in appropriate patients needs to consider these other diagnoses, and I really don't have time to go through any of the details here. So in summary, the diagnostic workup for these patients here in 2023, I'm not going to go through the details here. I just want to present the framework here, that the box at the top is unquestionably the most important point. That if you can't even get to the point where you're at least suspecting that MCAS might be an explanation for what's going on in the patient, then how are you ever going to actually be able to diagnose the disease? I mean, you have to at least be able to recognize a possibility that this pattern of chronic multi-system inflammation plus minus allergic issues plus minus dystrophisms, you have to recognize that's the overarching pattern in the patient. And when you see a patient who has that pattern, it becomes possible that they have MCAS. I am not saying that every patient who has chronic, mysterious multi-system illness has MCAS at the root of it. I'm saying that in the patient who has the overarching pattern I just described, it becomes reasonable now to at least suspect that maybe MCAS might be the explanation for what's going on here. So once you have that suspicion, then you go on to initial testing, which sometimes can be as simple as just checking a tryptase level. And if it's remarkably elevated, fine, go do the testing to look for the very rare disease of mastocytosis. But if tryptase is not elevated, don't go thinking for a moment that the patient cannot have a mast cell activation syndrome. It's just that instead you fall down into the bottom box here, where you have to go looking for elevated levels of these other mediators beyond tryptase. And at present, unfortunately, it is somewhat technically, logistically challenging to do these tests. Again, they can be done. You just have to learn how to do them. And actually, they can be done here in Australia as well. That's fairly new in just the last few weeks, actually, but they can be done. The prognosis, very briefly, just want to give the good news that for the vast majority of these patients, as best as we presently understand from the preliminary research, most of these patients will live a normal lifespan. So obviously, improving their quality of life becomes crucial. Um, so the treatment, again, no time to go into details. I just want to briefly mention the highlights here that we try to identify and then avoid as best as possible the triggers. We try to inhibit the mast cells' production of various mediators, try to inhibit the release of various mediators. If we can't prevent them from being released, then we try to block their actions once they have been released. I want to point out that this is not a cancer. So cancer-focused therapy, so-called cytotoxic chemotherapy, really doesn't have any role in the management of MCAS. And cellular therapies like stem cell transplantation, in theory, might be helpful for certain very select MCAS patients, but this is a very expensive, very toxic treatment. And basically, nobody should be doing stem cell transplantation for MCAS except in the context of a carefully designed, closely monitored clinical trial. And there are no such clinical trials underway at present, and there probably won't be for a long time to come. The last bit of business here regarding treatment is that if in the end you can't even block the actions of the released mediators and all these secondary consequences develop in the mediators, well, you do the best you can in controlling those issues. I'm going to fly through these next few slides. We'll just go into the details of all these steps. We don't have time to go into all these details here. There are various complementary, sort of natural herb supplements, that sort of thing that can help some of these patients. Even some non-pharmacologic therapies can be helpful. These pictures, these crazy looking pictures off to the right, actually illustrate that in many places throughout the body, if you look under the microscope, the mast cells physically abut the neurons. In many places throughout the body, there is constant mediator crosstalk going on back and forth between the mast cells and the neurons all throughout the body. And this leads us to understand there actually are certain neurally directed therapies, including behavioral therapies, that can wind up helping mast cell disease to some degree. A brief listing of some of the diseases that have no known cause. These are all multi-system inflammatory diseases that my profession has identified over the decades, and we still have no idea what causes these diseases. And based on what I've been seeing in my practice, seeing thousands of mast cell patients over the last 15 years, I think I can be excused for at least coming to suspect that some proportion of the population of patients bearing each of these diseases probably has some variant of MCAS at the root of it. But this is going to take armies of researchers, decades, if not centuries of effort to unravel all the biology of what's going on here. So an uncountable number of directions to go in further researching this disease. So ask what questions you want. Don't be surprised if my best answer is we don't know yet, but give us a few decades and a few armies of researchers and we'll probably get to the root of it. So in the end, this is the last real slide here. Where do we need to go? We need to improve our diagnostic techniques, in particular, get to the point where we can much more easily probe for the mutations that we can't presently probe for in the clinical, and we can do it in the research environment. But that very specialized genetic testing is not yet migrated to any of the clinical laboratories yet, and I'm expecting it'll be at least 10 to 20 years before that testing becomes clinically available. So until then, the best we can do is use the diagnostic techniques I've already outlined, and they are challenging, but when you're talking about a patient who might be living another 20, 40, 70 years with all of this illness, you can't legitimately say it's not worth going to the effort to try to run these tests, to investigate this and figure out whether the patient really has MCAS. So we need to improve our diagnostic techniques. We need to better understand what's causing this disease. There's some research being done here. We're beginning to get some ideas what's really at the root of this. We certainly need to get much better, but we have no end of drugs to help different mast cell patients. We just don't have any way yet of reliably predicting which drugs will best help which patients. So a lot of research needs to be done to better predict which drugs will help which patients. And of course, we need to improve education of everybody about this disease. And I'll just leave the final slide there as a summary. Sorry for running over time. I get excited talking about this. And it's complex, and there's no question that complexity just takes time. So thank you for your patience. I'll be happy to shut up and take questions.
You want me to stay on here?
Yeah.
Oh, okay. Thank you, Dr. Afrin. That was really enlightening. I might actually just turn my video on so people know who's speaking in the background. There are a lot of questions, and I think we'll start with what a lot of people out there are, I can see the questions all coming right through now. They're all targeted around, you're aware that in Australia we've had very limited access to testing in the MCAS space, and so most people out there would recognise a lot of what you've talked about tonight. They've gone to their doctors, they've been tested with a tryptase, it's been negative, and that's the end of the road for them. So you did open the bag and let the cats out in terms of there is now some availability for testing in Australia.
Actually, there's now good availability. Okay. There is now one laboratory. Previously, my understanding was that tryptase could be tested and N-methylhistamine could be tested. And chromogranin A could be done privately. That was about it. And You could probably, if you went to enough effort, you could probably persuade a pathologist to do CD117
Yes,
staining,
correct.
but
Yeah.
it often took
Yeah.
effort to put it charitably. But now I've heard in just the last, literally just the last 3-4 weeks, there's a laboratory, a commercial laboratory here in Australia. Again, I'm not here speaking on
Sure.
behalf of them, but
Yeah.
just to help patients and so they can help guide their doctors who may not yet be aware of this development. But there is a commercial laboratory. I understand they provide service all throughout Australia, a laboratory called NutriPath. And they are now offering the prostaglandin D2 testing and the 2,3-dinor-11-beta prostaglandin F2 alpha testing and the leukotriene E4 testing. All of these other tests that are highly valuable in very specifically detecting mast cell activation. See, one of the principal problems we have here is the mast cell produces, so many mediators. Most of them we actually cannot presently measure in the clinical laboratory. We can measure them in the research laboratory. That's how we know they exist, but you can't measure them clinically. And of the minority that we can measure in the clinical laboratory, the majority of those are not particularly specific to the mast cell. So in the end, there's only a handful or two of mediators the mast cell produces, which we can measure in the clinical laboratory and which are fairly specific to the mast cell. And in just the last month, many more options in that regard have become available. It will be very important for patients to work with their doctors and the laboratory staff to make sure that the samples that are sent for the mediator testing, the samples have got to be kept chilled continuously.
Yeah, which has been one of the issues, I think, with Australia being as spread out as it is in accessing this even through some labs.
So it can be done, but you just have to work through the logistics of it.
So I'll move on from that. We have a few questions around atypical anaphylaxis, and we see that in our population here, particularly the sickest of our patients who do end up in hospital from time to time. Our physicians that treat them in there are always a little amused by the fact that they all present with the same atypical anaphylaxis reactions to multiple different medications as well as anesthetics. And so what's your view on that atypical anaphylaxis? Is there ever a role for an EpiPen in these patients?
Usually you don't need epinephrine in those patients. Epinephrine is usually needed when you have classic frank anaphylaxis where there's so much edema in the throat that the patient literally cannot breathe or cannot swallow. That's imminently life-threatening. You have got to reduce that swelling in the throat immediately. And there is nothing that will reduce it faster than epinephrine. But epinephrine also has a range of other effects in the body. And as long as the patient is still able to breathe, I understand it may not be comfortable, but so they may be having some problems breathing, but fundamentally they're still breathing. They're still swallowing, maybe not perfectly, but at least they're getting their saliva down. There is opportunity there to administer the other treatments for mast cell disease that usually can pretty quickly, not quite as quickly as epinephrine, but pretty quickly gain better control over the situation, like extra doses of H1 blockers, H2 blockers, benzodiazepines, non-steroidal anti-inflammatories, at least in patients who aren't triggered by them, steroids. You, of course, want to administer these drugs in formulations that will get into the bloodstream as quickly as possible. So if you have a choice, you know, IV would be the best, or intramuscular, or a rapid dissolving oral formulation, or a liquid oral formulation. Any of those would be better than a standard tablet or capsule that has to get down to the stomach and dissolve and release its medicine.
And so on that, really, so this is really a patient question, and there's a few questions around this. We see, and a lot of patients experience adverse reactions to vaccines and anesthetics, and because we have a high vaccination rate in Australia, obviously the COVID vaccine became something that was a prominent concern for different people. What's your recommendation, or do you have any around whether different types of COVID vaccines are more likely to precipitate a reaction, or how should people prepare for vaccination if they have these kind of disorders?
Well, if a patient is known to have a mast cell activation syndrome, then preparation is reasonable, and usually it's just extra dosings of H1 plus minus H2 blockers, sometimes a non-steroidal also thrown into the mix there, starting shortly before, you know, an hour or so before the injection, and continuing, you know, for the next, you know, 2-3 days is usually all the protection they need. But in terms of which vaccine is more likely or less likely to trigger a reaction, it's entirely dependent on the individual patient and the particular variant of MCAS that patient has, as to whether any given product administered to that patient is actually going to trigger a flaring of their symptoms. And this actually provides an opportunity to make another very important point here, that yes, there are a few classes of drugs that really do have the ability to trigger the activation of mast cells. For example, to one degree or another, all narcotics, all opioids are triggers. There are some people, fortunately not many, but some, in whom the non-steroidal anti-inflammatory drugs absolutely are triggers. There are certain antibiotics, there are certain anesthetics that just naturally are triggered. And I should mention too that alcohol and smoke of any type often are potent triggers. But in the vast majority of scenarios where a mast cell patient is newly trying a medication product by any route, oral, IV, whatever, and pretty quickly out of the starting gate, you know, within the first few doses, maybe even the first dose, they start having an adverse reaction, it's almost never the drug in that product that is actually what's triggering their dysfunctional mast cells to further activate and spew out all those mediators that are what's actually causing all the symptoms. And instead, it's almost always one or more of what we call the excipients, the fillers, the binders, the dyes, the preservatives. Almost always one or more of the excipients is actually doing the triggering. So in those scenarios, in general, there are always exceptions, of course, but in general, no, you don't go giving up on the drug just because you had an adverse reaction to the first formulation of that drug that you or the pharmacist randomly pulled off the shelf for you to try. No, you look at the ingredient list, you try to figure out which excipient is the trigger. I understand the challenges in doing this, but you try. And then you go work with the pharmacist. You try to identify alternative formulations of the same drug, same dose, just with a different excipient package, not containing the suspected offending excipient. And you try that product. And if you have a better experience with that product, you just proved it's not the drug that's the problem, it's the excipient. And this becomes incredibly valuable information to add to the patient's allergy list, because some of these excipients get used in thousands of medication products. And if you react to a given excipient when it's in one product, you're sure going to react to it when it shows up in any other product.
Yeah. So I might jump around a bit now and go back to one of the things that you mentioned early on in your talk. You were talking about the impact of MCAS, or mast cells in particular, on growth in patients, and how that can inhibit that. And what we see, and a lot of people have asked about here, is there tends to be an association and a larger prevalence of endometriosis and adenomyosis in our patient cohorts, both in POTS, Ehlers-Danlos. What's your thoughts about the relationship with mast cells in the generation of those diseases?
Again, I'm not going to go saying that every patient with endometriosis has some variant of MCAS at the root of it, but based on what I've been seeing in my practice for the last 15 years, I think it's almost certain that there are some variants of MCAS that, through God knows what particular patterns of aberrant mediator output, they do seem to have the ability to drive these abnormal pelvic tissue growths. And when you finally get the mast cell, when you finally identify there is a mast cell disease present, and you finally get that disease under control with one mast cell targeted regimen or another, that's when we see these tissue growth issues finally stabilizing, and they either stop progressing, or at least they dramatically slow, retard their further rate of progression.
Yeah. And so I guess on that, even with the lab that is now doing testing in Australia, it's going to be quite difficult for a lot of our patients to find mast cell aware clinicians, get that testing. How important is it actually to identify any of those markers in these patients if they have all the symptoms of mast cell? Should they just be seeking treatment?
That's an excellent question. And you get to the issue, it basically is an issue of, will it serve the patient well enough? Will it be sufficient to make what we would call a clinical diagnosis, the clinician's best guess as to what's going on, without any laboratory proof, just based on symptoms and possibly response to empiric therapeutic efforts? Is it sufficient for the physician to guess that's what's going on? And I understand, listen, medicine is as much art as it is science. And wherever there is art, there is style, and different physicians have different styles. And I understand there are many physicians out there who, for various reasons, many of which are hard to criticize, they just are not going to pursue the testing. They are comfortable, they are satisfied in making clinical diagnoses and proceeding with all manners of treatment trials, mast cell targeted treatment trials in those patients. And we're so early in our coming to understand this disease that I don't think anybody is in a position to really criticize that approach. The reason that my own style has been to try really hard to find the laboratory evidence of the disease in the patient before pronouncing a diagnosis and trying much in the way of treatment beyond antihistamines, is that most of my patients are going to have to be dealing with lots of other doctors for decades to come. And most of those doctors are going to have never heard of this disease before. And even if they have heard of it, in truth, they'll have no significant familiarity with it. They're not going to understand, they won't accept, they won't believe that this is the root issue. And in my experience, when a physician does not fully appreciate that this is the root issue, and you have got to pay a lot of attention to this disease and the impacts it has on everything that's going on in the patient. When the physician doesn't believe it, doesn't accept it, that's when it becomes all too easy for the physician to start making treatment decisions that are not going to be in the patient's best interest. And I think that a patient in this day and age, where most doctors have never heard of this before, they're going to have a much easier time of convincing their other doctors who have never heard of this before that they really do have this disease. It's the laboratory evidence that's going to do the loudest talking by far on the patient's behalf in convincing their other doctors they've got this disease. So that's why I emphasize laboratory testing, but different styles for different doctors and different patients. I understand that.
Now, I think most people are familiar, and you talked around the H1, H2s, the sodium chromoglycate, which we are somewhat familiar with. And I think a lot of our patients, particularly in the advent of long COVID, have been able to source some of these therapies. I think you've already spoken to the excipient problem, which we actually have in one of our medications here in Australia. It's a nice big red tablet that we give to people as a H2 blocker. So I'm not sure that that's really, and we do notice a lot of reactions to that. What's your thoughts on the H4 blockers, and particularly LDN, which we've noticed, and there's a few trials going on, one up in Queensland in long COVID. We do see our patients respond to that in multiple ways, particularly pain, but other ways.
There actually are some H3 blockers that are beginning to come on the market. H4 is in development. And I think these drugs have potential for helping some patients with mast cell disease, but it's far too early at this point to begin to guess which patients are going to be best served by those patients. Low-dose naltrexone, a curious molecule, it has anti-inflammatory properties at the low doses. We don't really understand how it brings about its observed anti-inflammatory effects. There's no question it helps some mast cell patients, but again, there's not a single thing I've been able to identify yet in the history, in the physical exam, or in any of the laboratory testing that will allow me to reliably predict which patients are best going to respond to or respond at all to LDN. So
our POTS patients.
There's no question about the frustration here in the trial and error that's needed to work out which medications are going to be helpful in the individual patient. The good news is that we've got a lot of things that have been found helpful in various patients. That's a much better situation than the alternative. And most of these patients, in my experience, actually do sooner or later manage to identify some cocktail of mast cell targeted treatment that really does get them to the goal of feeling significantly better than the pre-treatment baseline the majority of the time. It's just we don't have any way yet to reliably predict which, but they're going to likely live a relatively normal lifespan. This is not a cancer where we're racing the clock to find any treatment at all that will be effective against the disease. There are some patients in who manage to find very effective treatment in just a few weeks or months. There are some mast cell patients who have been diligently working at these medication trials for a few years. But either way, they're almost certainly going to survive to get to the point where they have identified a helpful cocktail. And once they have a helpful cocktail, they be expected to have a better quality of life for the remainder of a normal lifespan. So there's no disputing this. This takes an enormous amount of patience and persistence and a very methodical approach on the parts of both the patient and the treating physician in stepping through the trials of these different treatments one at a time. It only takes about a month for trying each of the drugs that makes biological sense to try the disease, to figure out whether it's going to make a significant difference or not for the individual patient. If the patient comes back in a month and the best they can tell the doctor about their experience with the drug is, it maybe helped a little bit, that's not worth keeping in the regimen for the rest of the patient's life. But when you find the particular drugs that happen to be the right molecular keys for fitting into the particular molecular lock that is the individual mast cell patient's particular variant of this disease, they come back in just a month and the doctor walks in the exam room and his head spins 360 because he can't believe how much better the patient is. I mean, those drugs are the keepers. Everything else you ditch. You move on and try something else, and it takes patience, persistence, method, and all that takes time. There's no getting around that. But if you're persistent, you'll probably find some cocktail that'll significantly help. So
now
it's finding the doctor that's
yes,
willing to work through all of this with you. That's the biggest challenge at present.
That's right. Yes. The next question, we're almost at the end, but this question did come up a bit and I'm curious about it too. We have a large cohort of POTS patients with Ehlers-Danlos syndrome. And as you know, that's a genetic, predisposition to that condition. And so we actually see successive generations of people with it. Now, even in our clinic, we see both things. We see people who seem to develop connective tissue hypermobility, and we have some specialists that have noted that too when we've noted it. But then there also seems to be these children who are born with the hypermobility of their connective tissue and the same predisposition for all the skin tears and different things. So how we were talking, and you've talked a little bit about the association with mast cell. Which is it? Is this a genetic condition that people are predisposed to mast cell activation syndromes, or do the mast cells have a role to play in that genetic condition that's causing the connective tissue to be?
There's a strong familial propensity for this disease. And again, we know from the research that most of the mutations that can be found in the dysfunctional mast cells that are driving the dysfunctional activation of the mast cells, we know that most of those mutations are not inherited. They're not inborn. We know that most of them are acquired mutations, acquired at various stages in a patient's life. But at the same time, it's very clear that there's a strong familial propensity for the disease. And if there's a familial propensity, then something's got to be getting inherited. But if it's not the actual mutations directly driving the misbehavior of the mast cells, if those are not the mutations that are being inherited, then what's being inherited? And this research is at an even more preliminary state at this point, but we're beginning to, we're increasingly suspecting that there really are mutations that are being inherited, but they're not genetic mutations. They're epigenetic mutations, and the end effects of these epigenetic mutations actually creates increased risk for the development of the genetic mutations.
Yep.
And so in a given family that's affected by MCAS, one affected family member can manifest MCAS in a very different fashion from the next and the next to the next. So these families go to the family doctor and they say, "Doctor, why are so many people in our family so sick, but everybody is sick in a different way?" And the poor family doctor, who has not been taught that there is a disease that can behave this way, the best he knows to tell the family is, I'm sorry, but it's just bad luck. Well, no, that's not the case. It's much more likely there's a reason. It's just not a reason the doctor has been taught about yet.
Well, Dr. Afrin, I think we're coming towards the end of our time. So thank you. There are a lot of questions on the Q&A. What I might do is actually go through and get rid of some of the ones that we've answered. There's some pretty complicated ones in there from some of our doctors. So maybe if you had a couple of minutes, you might be able to give a brief response to those in the Q&A. But you'll be able to catch Dr. Afrin at a few more talks around Australia. He's presenting quite frequently at some of the dysautonomia conferences that are held around the world. So there will be more access to him for those. So thank you very much for an excellent presentation tonight. If you're in Adelaide, actually, you can come along to SAMRI tomorrow, which is on North Terrace at 12:30 to hear Dr. Afrin speak again. And you'd be very welcome to do that. I think we have another slide, do we, Celine?
I might just ask you to stop sharing, Dr. Afrin,
Sure.
if that's okay.
We'll just get these slides down.
There you go.
Thank you.
Beautiful. So we're just going to put up a slide about some upcoming events for you. So this is part of our POTS for Practitioner series that we just happen to have Dr. Afrin in Australia for this, but we'll be having our next POTS for Practitioner seminar is on the 29th of May. We're going to have Calum and Jackie come back to speak to us about looking after patients with moderate to severe POTS, and particularly the bed-bound patient for that. Maybe you can actually use that QR code if you'd like to go on and scan that now. And if we move on to the next slide, we're also very pleased to say that we're going to have a conference that's going to run in April. Our last conference was actually last year and Dr. Afrin presented at that, but we're going to have a 2-day conference in April 5th and 6th. It will be here in Adelaide. We're going to broaden that conference out to really look at the redefining of care, looking at dysautonomia as a large group, and particularly the comorbidities that go with that. So things such as Ehlers-Danlos and Mast Cell, and many of the other conditions that you'll be familiar with. And we're particularly going to have a patient day that will speak to patient issues. So that will hopefully pad out that conference compared to last year. And I'd also just like to thank Sammy. Again, I'm not sure if Sammy's online actually watching, but thank you, and to Peter for facilitating this webinar, and Dr. Afrin's trip here to Adelaide. We really appreciate it. And thank you again for joining us.
My pleasure.
Thank you, everybody. And good night, and we'll see you at the next webinar.